of tissue we get. That's what Shruti was talking about. And amount of tissue is a challenge which I'm also facing, because not every place we are able to do it. And I'm shifting to liquid biopsy for a lot of patients. So I've started doing it because it seems to be equally as good. But because problem comes, patient has come again, repeating a biopsy, getting enough, waiting for a repeat biopsy. It's a challenge in sometimes for me. So I've started doing liquid biopsy.
So tissue is another cost, and now the tissue. Yeah, correct.
That turnaround time is also an issue. So
Turnaround time is an issue. Yes, that is true. So third one. Anyone else? Cost, turnaround time, and the tissue. No. Okay. So anyone else in the audience? So these are the three issues as far as the panelist is concerned for this testing. और कोई problem नहीं, Bhavesh? All good. इस तीन चीज को छोड़ के, if 3 hours solution is there, adoption will be higher. So again, this is interesting. Nasik, you're able to get it. So you leave it to private guys. They will take the tissue and get the test done. But I totally agree. All these three, getting a good, pulmonologist, intervention radiologist, or a surgeon to get a biopsy done is a challenge. And we have a center in Varanasi mein, biopsy not an issue now. Oh, good. So that is there. So we have another center in Muzaffarpur. We don't get person to do biopsy. It is so tough to get a person to do biopsy. Now we have tried to get, we have tied up with someone, to get a biopsy done. Otherwise, you're not able to convince people to do biopsy. So radiologists, they are very happy doing diagnostic. They say, no, needle nahi dalenge. I have a colleagues in Patna. I say, okay, not possible, not easy to get, people to do biopsy. So he used to do liquid biopsy more, but looks like things are better. Turnaround time again. Any solution from anyone? I think so. The only issue is that more sample needs to go to one lab. That is the only way. So problem is that we have got too many labs.
So what we have done as a hospital is that we have tied up with one lab and we asked them to give the entire head-to-toe tests available in a subsidized rate so that we can pass on that benefit to the patient. And we tell them that we can offer these many patients per month.
But how many days did they give you the report?
So for lung, we had put a TAT of 2 weeks.
Oh, wow.
So within 2 to 3 weeks, we get it.
Bahut badhiya.
Very infrequently, we get it on, 2 weeks, at 2 weeks. But yes, but it's quite okay before the second cycle of chemotherapy, the report comes, if we have started treatment. So
this is very important what Dr. Shruti is saying. We struggle because there is a fragmented clinician practice is there, and there is a fragmented lab is there. So the tissue numbers are less, so you don't get report within 2 weeks. And if you get within 2 to 3 weeks, that is very nice. The way to negotiate with the lab and to get those reports early.
Sir, one more point. So ideally, we want to order both a DNA as well as RNA based NGS. Okay, so but if we order DNA NGS alone, or we sequence it in a way that we do a DNA based NGS, then do an RNA based NGS, possibly TET could be reduced. Means, is that a valid statement?
Can you repeat? Sorry, I didn't get the last 2 lines.
So ideally, what we want from an upfront NGS is both DNA as well as RNA NGS. Okay. But if you do sequentially go in for a DNA based NGS and then subsequently do an RNA based NGS, possibly TET can be reduced.
Okay, so you get DNA report early and RNA report is usually a bit later subsequently.
Actually, one more means based on the patient profile, this can be selected. So a female patient, non-smoker, in that patient, the RNA NGS is very important. So possibly based on the patient profile, we can select.
Possible, because whatever I have talked to the lab, again, there are lab people here, doing segregating it and doing becomes more cumbersome. So if someone can address that logistically, why not? But usually whatever we have understood that, I have understood that panel do it together. Go ahead.
Yeah, it is very important to keep a track on the TAT. Individually, the clinicians fail to do that. But if you, what happens is when they promise, the TAT is very less. And later,
don't leave them. So they have commit TAT. So go after them. Why?
We have to ensure that the TAT is, because in private practice,
so it's like a Domino's pizza. So 20 minutes mein nahi aaya to it is free.
We've done that. So
oh, good. So देखो ये बड़ा important है. 20 मिनट में नहीं आया तो free. ये होना चाहिए 20 दिन में नहीं आया तो free. So I think so med genome mein dekho, yeah, this can be a very good way of your scientists to be working hard. कि वो लोग तो 20 मिनट में नहीं आए तो test is free. So then they will be doing it within the time frame. So these are important solutions. Somehow this has to come from the society. Now coming to the next question, Akhil, next question, exon 20 insertion testing. Any triggers or we do all of them? Anyway, we do it.
Anyway, we are doing it.
Anyway,
even in RT-PCR, it is included. But as Vijay sir highlighted, that if we do NGS, we'll get more exon 20 insertion because all exon 20 insertions are not covered in the standard RT-PCR.
RT-PCR, yeah,
Yes.
correct. So NGS, it is included by and large, unless you have a hotspot mutation testing. That is something to understand. I know maybe Dr. Amit can comment on it. Amit, do you want to comment for the audience? A hotspot mutation testing and then gene full testing, which if it includes EGFR anyway, exon 20 insertion, all of them will be there. Maybe you, because sometimes your lab, be careful, you may get NGS testing, but it may be what Akhil was pointing out, you can have NGS testing which will be bit like a PCR, means like those mutations only getting tested. So that is not you going to give the report. I know what you are looking for here, what Akhil was pointing out.
Yes,
Go
for the hotspot testing, we are talking about the few genes.
Few genes and few mutations.
Few mutations. So you have to ask the lab if they include the common one. And now most of the lab have the exon insertion 20 category. That is not a problem.
And then if your exon 20 category means everything is there.
So yes, so they're going to read end to end to that 4 important exons, and whatever comes, they are going to report it. So nothing to worry on that. But if you're going beyond the EGFR, then you may have challenges. That's what you have to keep in mind.
So I'll tell you, adding to what Amit said, suggested, and what Akhil was suggesting for PCR, but it's also true for NGS. Sometimes NGS cost may be less because it is not only hotspot for gene, it is hotspot for mutation also. And then it's a challenge. Hotspot for being gene is okay. So if you do EGFR, exon 19, 20, 18, and 21, fine, you will get all the details. But the moment it is for hotspot mutation, that is not explicit, then there is a challenge because one of the times someone showed me, we do ALK testing and fusion was not there. So he's like, I'm doing ALK kinase domain mutation, but fusion was not there. I say, hey, this doesn't help. But that person was claiming, I do ALK. They said, that's fine, you do ALK, but not what we wanted. So being a bit careful for exon 20 also will be important if we want to know what they are doing in this setting. Any experience, Vamshi?
Bad experiences only so far.
Okay.
I use only chemo. I would prefer actually using paclitaxel and carboplatin rather than a pemetrexed. I usually go with pacli-carbo. Again, handful of patients, but that's what I have seen. They respond better to pacli for some reason.
Shruti, experience?
Sir, we have the Papillon study going on. So a lot of patients for exon 20 insertion. So I have like a decent exposure to chemotherapy for these patients. And I have also tried the Atezo-Bev pacli-carbo combination in one of the patients who progressed after amivantamab. So he is in a complete CR.
Oh, achha,
So and now on, yeah,
amivantamab didn't do a good job.
he received 6 cycles. So
So, okay. No. That's happened. Not everyone does good with every treatment. There is no such treatment in the world. Everyone does good.
but there are patients who are currently
well.
on treatment doing well. So
No, I agree. Similar experience for me also. Deepak, any experience?
No, sir. Only prior to amivantamab became available. So prior to that, I was using pemetrexed carbo with gefitinib.
Okay. Good. I know, Manoj,
A handful of patients responded to chemo initially and then progressed.
on progress.
Probably now new molecule we may try. I haven't tried it.
Tried it. Okay. Akhil,
As a part of study at TNH.
how was your experience?
Yes, sir. It's as you said, sir. Some patients doing well, some not so doing well. But
How to administer the some
infusion reaction is a concern. But
want to give some those words because you have some people who how to use it, what precaution, and what is the experience overall.
Yes, but the infusion rate of 50 ml per hour now is doing much better, and we don't see so much of infusion reaction with the unmodified regimen, which we are now using. So with reduced infusion reaction and dividing the dose in day 1 and day 2 in the first cycle becomes very important, and that helps a lot.
Okay.
760.
Yeah, 350 on day 1 and day 2 750 in a patient of below 80 kg.
So what Akhil is trying to convey, don't forget the weight, don't forget the initial days, I'll say at least 2-3 weeks is something which is concern, and how do you give the first dose is an issue. Be careful. If that is taken care of, it is usually a good drug to handle. Ashish, any experience sharing for amivantamab? No. Okay, no issue. You next time we have again a discussion, because MOC has a lot of experience by and large for most of the thing. So Akhil talked about the challenges. Akhil talked about infusion reaction. Anyone else wants to share infusion reaction and their experience? Bhavesh, Preeti, anyone? Kajal, Tarachand? No infusion reaction. No experience sharing. Anyone in the panel?
So with the split dosing, day 1, day 2, I have not seen as of now 5 patients. So not yet I've seen. The other toxicity takes a toll when the dose escalates. So
okay, for example,
the mucositis, the nail paronychia is
nail changes. Yes, nail changes.
For paronychia, many of them require dose interruption, reduction, going back to a lower step dosing. So that is an issue. I have also seen peripheral edema, but it was not that bothersome. The nail and they get folliculitis on the scalp and all, and nose, and that does interfere with the quality of life also.
So we are learning. I think so. Most likely, after some time, we'll say it's a bit like sunitinib. Initially, it is really painful, but later on, we realize, okay, you can handle it. So, but good drug. A good number of patients they benefit with if they are able to take the drug. Anyone? Any last comment?
So one more comment. There was a comment from the audience that what is the benefit of doing NGS when you cannot give the treatment? So for that, I would like to give a comment, our experience. So in our country, there are multiple studies also ongoing at different parts of our country. Some studies are going at TMH Mumbai, some at Varanasi, some at Rajiv Gandhi, and some at various other centers. So I will give you an example. A patient who was MET exon 14 skipping positive, residents of Mumbai. Since we had trial at TMH Varanasi, patient came from Mumbai to Varanasi to take the treatment because he was not, if we can give the treatment commercial basis, that patient was not affording it. So this is the way which we should find and not think that the cost of the treatment is so high. So why to do test at all? Because we have treatments available. For RET, we have compassionate access programs available. So these are important ways and means which we should adopt so that the patients get the best possible treatment.
I totally agree with you. Yes, please.
Akhil,
I want to hear more on this.
Yeah, Akhil is talking about an oral drug. For amivantamab study, patient is flying from Delhi every 3 weeks only for the study. Ullas sir's patient now taking treatment in Nashik. So
yes,
with the connect and the studies having good support system, even sponsoring the flight ticket to the patient, which is very, very good for the patient's benefit. So
absolutely. Anyone else? Yeah, because this is very important for take home message to audience who don't deal with these things. Providing you do have alternatives. Anyone else?
Even we can have a database of our patients, or like if I'm not able to use, but next 5 years down the line, my colleague may have data of Indian patients, which mutations are common.
Okay.
So I think that can be proactively done in most of our patients.
To get together and have data about it. Anyone else want to share this part regarding this? Vijay getting access to treatment on trial, compassionate basis. Want to comment on that? Highlighting why idea should be that chicken and egg situation should not be there. You can have both of them and it works in life. So, yeah.
With the advent of targeted therapy and immunotherapy, more and more trials were not like what the trials used to be 10 or 15 years back, where out of 100 molecules, 1 molecule is to come. Nowadays, it's like after the phase 1, you have good amount of data. You know that, okay, we are actually doing the trials of phase 2 or phase 3 for many times for the sake of courtesy, like FDA would give an accelerated approval and that would be conditional saying that you complete the phase 3. So and many of us, like this is one of the commonest discussions which will be going on all oncology groups. I have a patient of so and so mutation. Are you having a trial? Are you having a trial? I never used to see this discussion happening 5 years back or 6 years back. In fact, I think there is a time where I think ISMP or some national body needs to have a bank of which mutations, which studies, which centers are recruiting, because that is going to help a lot. Because what the access to my patient today is actually limited on what access I have with my friends. It's not that I have access to all PIs of this country.
अच्छा मैंने मेरा क्या हुआ था sorry. So it was a very important comment, and I really wanted, especially there are many young oncologists, and I want this word to spread. I'll give you one by one example what Akhil said, where you have access to treatment in many situations and why this test should be done. If you take EGFR mutation, you had a trial of osimertinib, lazertinib, till recently, just got, I think so, recruitment got stopped. Exon 20 mutation, amivantamab, you have access till just now. Mobocertinib, J&J may not like it, but mobocertinib, you have access now also available. Exon 20 insertion. Take ALK and get the ROS1, both you have a drug available, which is within the cost of most of the scheme available in India. Any state government scheme, it is available. For RET, NTRK, both you have at this moment, a compassionate basis access available. You have to work a bit, you have to do paperwork, you will get the drug. For CMET, there's a trial running at multiple centers, you can get those drug available. KRAS, you don't have at this moment. We are at this moment, those moments struggling a bit on this part, so that we don't have.
KRAS G12C trial is going to come within the next 2 months, sir.
And you will have this in the next 2 months. Keep your follow-up of the patient. What Akhil and others were trying to convey to people in the audience and to spread this word. At this moment, not doing tests because treatment is not available, that's not really completely true. There are issues. That doesn't mean access to treatment doesn't have many barriers. There are many barriers, but it's not like people can't get it. They are able to get it. They are able to do it because they know there are multiple ways to get access. Buying and getting access is one way to do it. So that was being conveyed. Thank you so much. Thank you so much. And thanks the panelists and the audience. Thank you.
Thank you so much, sir. Thank you, Professor Kumar, and all the esteemed panelists for such a wonderful discussion and insight.